open the show this evening. So you got me tonight.
Okay.
So yeah, so I think what I'll do, she sent me over her PowerPoint slides, so I'm gonna put that on here. Can you guys see the slides?
No.
Can you
There
see
we
them
go.
now?
Yep.
There you go. Okay. So I think I'm gonna get started because it's 6:32. So whoever else joins us will just be popping in as we go along. But I just want to welcome all of you to our June Northwest Wayne Family Forum this evening. We're excited. We have a great lineup of speakers from Hagera, and I'm sure we'll all learn a little something extra that we probably didn't know. So much has changed, it seems like, in the last 15 months, and it's a never-ending process. So we're excited about that. But for those of you who might not know about Families Against Narcotics, our mission is to provide education, resources, and support for family members who have loved ones that struggle with the disease of addiction. And we have our monthly public forums. They're always the first Monday of every month for our particular chapter. There are like 22 chapters in the state of Michigan. Most all of us are online. So if Mondays are, tend to be a hardship or what have you, we always record them, as you can see from the screen there. And you can go out to our YouTube channel, which is Northwest Wayne Fan, and you can find all of our recordings there. We've been doing that since January of 2019. So we have quite a few of them out there for you to learn from. And they're all they vary from any part of the community sector that is impacted by this disease state. We have a recording out there, which is really, really nice. Now we've got a nice library out there. We also have, each month we have 5 meetings every single month. So we have 2 grief support meetings that meet at they're now meeting in person. So each month we have 5. Oh, I'm getting feedback. We have so 2 grief support meetings, and they are actually meeting in person. They were virtual for the longest time, but due to the nature of just the topic, it was just a lot better for them to meet in person as opposed to trying to do things virtually. So we were excited. At least we have 2 out of our 5 meetings are in person, and they're at the PC L&O Club in Canton. And then we also have our Stronger Together family and friends support group. And that one has been really well received. Also, they meet on the 2nd and 4th Tuesday of each month. Generally, they meet at one of the city buildings in Canton, but due to COVID, obviously, they're still online as well. That one has picked up quite a bit because of the fact that it's just strictly for family members, and it's 1 hour long, and family members they go through kind of a process, like a 12-step that was created by Jackie Sanders and the team of people that are running it. Kelly O'Reilly happens to be on that team as well, and she's one of our board members. And so we're very grateful for this group because it allows for the family members to be able to come together, find out how they can gain strength during this crisis time of their lives, that they're dealing with their loved one who is using or maybe in recovery or in prison or what have you, and they all are able to kind of help each other along in this journey. So we're very, very grateful for that. Let's see. And we have our Hope Not Handcuffs program, which is a program where people can go to participating police departments. Ours happen to be Wayne and Garden City, and we just recently launched on March 16th. So we're super excited about that. So those are just ramping up. And I'm going to turn it over to Jeff Jones, because Jeff Jones is our Hope Not Handcuffs coordinator. And he's going to say a couple words about the training and the angels and how that program actually works. So go ahead, Jeff.
Well, we are always looking for new volunteers, new angels to participate. Individuals that go to the police departments and meet with the participants seeking assistance with their substance use, and help them connect with treatment options that are available. And we do have some upcoming training if anyone's interested in becoming an angel and getting involved in this program this Saturday at the Taylor Police Department. I will be linking in the chat the page for to sign up to for the training in case anybody's available and would like to participate and get involved in this great program that does save lives. So please, if you do have the capacity to join, I would be really appreciative of that, and hope to see some of you show up at the training.
That's awesome. Thank you so much, Jeff. And you can see on the screen here, it's a really simple process to be able to sign up to become an angel. If you know somebody that you think would like to become an angel, please share this site with them. The Families Against Narcotics.org/Hope Not Handcuffs is a very easy process for them. Just a few questions that they have to answer, and they can get signed up that way. So we also have a very active Facebook page. Lauren Rousseau, who is our president of our chapter, does a phenomenal job on keeping on top of current events as it relates to the opiate addiction, or just substance use disorder in general. And she's always posting the most phenomenal articles. I mean, some things that I have found extremely useful for my day job as well. So I really love all that she's done. I think you guys might too. If you haven't already followed us, gone out there, if you could like us and follow us, we'd appreciate that. Our speakers this evening, we're super excited to have Scott Shadle, and he's the administrator of substance use disorder for Hagera Health. We also have Melissa, sorry about that. Is it Tolstica? Am I saying that correct?
Yep.
Tolstica. Sorry about that, Melissa.
That's all right.
She is the clinical director for Hagera Health. And then Chris Odrosky, who is runs the Engage program. He's a program coordinator and peer support supervisor at Oakdale Recovery as well for Hagera Health. And I'll give more formal introductions after I get through with these brief announcements to just kind of share with you a little bit about that. Let's see. One last thing I'd just like to say is that we are always here for you. If there's anything in particular that you need or your family needs, please don't hesitate to reach out to us. If you hit, what's that? Oh, wait, I hear some talking. If you have family members that, you're just kind of in crisis mode or what have you, we have, our phone number and our email address, everything is listed out there. We definitely want you to know that we are here for you in the community, especially when you need us the most. And so we try to offer, the best support that we can to all involved. And we know that this is not just the individual's disease, it becomes a family disease because it just impacts everybody within the family. So we just want you to know that we're here for you. Our next public forum will be on July 12th at 6:30. Due to the holiday, the way the holiday falls, we moved it back a month. So please make note of that on your calendar and keep an eye on our Facebook page for more information. And you can also check out the website as the Families Against Narcotics.org Northwest Wayne Fan for more information as well. And as I mentioned earlier, we have the recordings on our YouTube channel. And I can't stress enough that while they're not professionally done, they were done by professionals. The content is really, really good. And it's just something that you can listen to if you like listening to those types of things in the car, what have you, when you're just kind of wants to learn a little bit. Please feel free to look through the library of presentations that we have. I think you'll be very excited about that. So, all right, so now what I'm going to do is I'm going to stop sharing my screen and come back to everybody. And I'm going to introduce our speakers. And what I'm going to do is I'm going to introduce everybody all at once. And so we'll go from speaker to speaker to speaker, so there's no break in that. What we would like is if you have questions, feel free to put them in the chat, or you can send them to me directly, however you feel most comfortable with. And I'm sure the speakers will probably let you know that if they would like, to have a lot of questions asked, because that's how we all learn from one another, correct? So Scott Shadle is the administrator of substance use disorder services at Hagera Health and leads the oversight and development of substance use disorder services for the organization. He received his Master's of Social Work from Eastern Michigan University in 2002 and is a certified advanced alcohol and drug counselor and certified clinical supervisor through the Michigan Certification Board of Addiction Professionals. Scott began his career in 1994 as a therapist working in residential and outpatient programs with adolescents and adults struggling with addiction. He was eventually promoted to multiple management positions and has served as a clinical supervisor and administrator for the last 13 years. Scott has been a speaker at many professional, collegiate, and community events and enjoys sharing his experiences, knowledge, and passion for serving the substance use disorder population with others. And we are also very fortunate to have Scott on our board for our Northwest Wayne chapter. So thank you, Scott. Melissa is the clinical director for Hagera Health and providing clinical and operational oversight for most programs and services. She has a master's degree in counseling and is a licensed professional counselor in the state of Michigan, as well as a national certified counselor. In 2016, Melissa obtained her certificate in integrated behavioral health and primary care from the University of Michigan. She is a master QPR trainer, question, persuade, and refer, and is also trained in critical incident stress management. Having lost 2 family members to suicide, Melissa has been passionate about suicide prevention throughout her career. As the lead implementer for the Zero Suicide model at Hagera Health, she developed a work plan for training staff on evidence-based practices for suicide prevention and post-intervention development of policy and procedures, data collection requirements, and quality improvement processes. She has expanded training into the community and has trained over 800 individuals to become suicide prevention gatekeepers. That's excellent, Melissa. Chris is the Engage Program Coordinator and Peer Program Supervisor at Oakdale Recovery Center at Hagera. Engage is a mobile substance use disorder crisis intervention team in Wayne County. Chris has been in long-term recovery from substance use disorder since October 6th of 2008. We're excited about that. And has been working in the addiction treatment field since 2010 in a variety of capacities, including outreach case manager, recovery advocate, public speaker, musician, performer, event organizer, peer recovery coach, and recovery coach trainer. Chris is also a founding member of 2 recovery community organizations, the Washtenaw Recovery Advocacy Project and Michigan Recovery Voices. He is a fierce advocate for and believer in multiple pathways to recovery. So please welcome our speakers this evening. Scott, it's all yours.
Thank you, Dara. I'm going to share my screen as well. So you should be able to see mine now. All right, excellent. So appreciate the introduction. We're happy to be here. We are all from Hagera Health. We're a large behavioral health organization in Western Wayne County, and Melissa's going to talk a little bit more about Hagera when it's her turn. What I'm going to focus on is just the impact of COVID-19 on substance use disorders and the use of drugs and alcohol, as well as the substance use impact on COVID-19. So I wanted to start out just talking a little bit about why do people use drugs? Well, and these are very general reasons. They're more individualized. When you talk to people, individuals, it's more specific to them. But these are just general reasons why people use drugs and alcohol. And so some of them are depression, to cope, to escape feelings, to escape memories, to escape unhealthy situations or what have you, boredom, stress, grief, illness. So there's a lot of different reasons why people use drugs and alcohol, and COVID has certainly had an impact on all of that. So one of the things that when you start, I wanted to find some research and look at really what impact has COVID had on everybody and their emotional and their mental health. So this is one study, and it was done in October of 2020, and it involved college students. And they asked these students a bunch of questions, and one of them was, how would you say your emotional health has been impacted compared to before the COVID-19 outbreak? And as you can see, is 62% of those folks said that it's either somewhat worse than before or far worse than before. So you can see that obviously the toll that it's taken on all of us has it's been a major impact on all of us in our emotional health and our mental health through isolation and separation from everybody. We were talking earlier about giving ourselves hugs versus giving other people hugs. It's been a tough time the last year and a half for everybody. This is the same study and just a different question. Which of the following mental or emotional challenges have you experienced in the past month? And you can see a majority of the people said things like anxiety, social isolation or loneliness, depression, difficulty coping with stress. And even though they're smaller percentages, there's still a lot of concerning things on here. Suicidal thoughts, and Melissa's going to talk a little bit more about that. Substance use issues, a lot of the impact that COVID-19 has had on all of us. Another study looked at anxiety disorder and depressive disorder in adults. And this study looked at folks in January through June of 2019, and 11% said that they had anxiety or depressive disorders. January 21, now it's up to 41%. So a 30% increase in those people feeling that they have again, they're struggling with anxiety, they're struggling with depression. And again, there's a lot of reasons for that with COVID. People struggle with it beforehand, but COVID has just really intensified all those feelings and the fear of getting sick to being separated from everybody, from loved ones, whether it be young people or old people, older people who have been in nursing homes or what have you, there's been such an impact on the separation, not being able to be together and be social and go to social events, whether it be go out to dinner or go to a support group face to face or anything like that. And so all these have just really intensified these emotional and mental health issues. And so when you go back to why do people take drugs, when you start looking at these again, depression was there before, but now it's more intensified. Now more people are experiencing depression. Looking at to escape, boredom, social isolation or loneliness was one of the higher percentages on that question. So again, that boredom goes from boredom to being lonely to be isolated from others. Stress of the whole, everything might be a job loss, might be just other things that we've lost with COVID. And it's not just the people who get sick, it's the loved ones of those people as well, and the loss that they've experienced and the stress that they've experienced. So obviously, if all these are reasons why people use drugs and alcohol, and then through this process, through that process, these feelings and these issues have intensified and become more common, then you're going to see an increase in substances. If we use because of depression, loneliness, boredom, to escape, and then those are more intense now, the substance use is going to become more intense. And so this was a study where these folks looked at results of urine drug analysis and found just positivity rate for cocaine, fentanyl, heroin, and methamphetamine. And what they found was that you can see as of March 13th, 2020, when the national emergency, the declaration of the national emergency for COVID, you can see a spike in substance use right away, which again makes sense. If that anxiety is increasing, that depression's increasing, that loneliness is increasing, these are the ways that that some people deal with those emotions and those situations. And so as those intensify, the substance use intensifies. And so we've seen a big leap in that. And while certainly, and especially in March, April, and May, when the stay-at-home orders were there, and we weren't going out or doing anything. You were basically stuck in your home for most of the time. And some people literally stuck in their home. They literally couldn't leave because of fear of getting sick, or because they were sick, or what have you, because they have all the risk factors that put them at a higher risk of getting COVID. And even though the numbers look in these graphs, some of them start going down, it's still higher than what it was before. And so not only does COVID have an impact on substance use, but substance use has had an impact on COVID. And so this is a study that was done where they looked at comparing people with a lifetime use of substances and recent use of substances, and the impact that that had on contracting COVID-19. And what they found is that people with a substance use disorder at any time in their lives were 1.5 times more likely to contract COVID-19 than those without a substance use disorder. So the substance, if their use of substances made them more susceptible to acquiring COVID-19. Those with a recent substance use disorder are more than 8 times more likely. So if which makes sense. More recent means you're going to have more physical impact of physical effects from the substances. And so, again, you're going to be more susceptible to obtaining COVID at that point. People with an opioid use disorder are a particular high risk for COVID, and we're going to talk about that in a minute. And then COVID-19 patients, with substance use disorders are more likely to require hospitalization and to die from COVID-19 than those without an SUD. So why is that? So they started looking at that. And so this is the same study. And the first set of bars you see are all COVID-19 patients. So they just looked at patients with COVID-19. Those patients that had a lifetime substance use disorder, those patients that had a recent substance use disorder. So lifetime being they had an addiction or used substances a while ago. Recent is obviously more recent. What they found that more than 40% of the COVID-19 patients with a lifetime or recent SUD diagnosis required hospitalization compared to 30% among all COVID-19 patients. So they're more likely, if they have a substance use diagnosis, they're 10% more likely, or 10% more of them required hospitalization. 10% of COVID-19 patients with an SUD diagnosis died compared to 7% of all study patients. And while we say, well, maybe 3% isn't that much, when you think about how many people have contracted COVID-19, that's a high number. Even that 3% is a high number of people. What was also interesting is hospital and death rates did not differ between lifetime SUD diagnosis and recent substance use disorder diagnosis, meaning that use of substances has a major impact and made them more susceptible to COVID-19. So, it didn't really matter if it was recent or 10 years ago or 20 years ago, they were more susceptible to it. So why is that? Why are people who have a substance use disorder more susceptible to COVID-19? Well, there's obviously a physical impact. When you use drugs and alcohol, there's going to be a physical impact in that. And a lot of that has to do with the heart and the lung. Opiates, as I said earlier, people are with an opioid use disorder are more susceptible because, use of opiates works on that respiratory system and slows that respirations down. And that's what leads to overdoses and that kind of thing. So it impairs that lung function, impairs heart function. Other drugs and alcohol impair heart function as well. And so those are the people, the heart and the lung, if they're not operating correctly, that's when people had difficulty with COVID-19. They were being put on ventilators and that kind of thing. Also, drug and alcohol use promotes the development of things like diabetes and hypertension. Those were risk factors. Those people who had, they knew early on that those, folks with those kind of, health issues were at a higher risk to get COVID than other people. And use of substances promotes that development of those disorders. So the substances really have an impact on your physical health, which really has an impact on your ability to not, to get COVID, but also have the serious side effects of COVID. There's also barriers to healthcare that people who struggle with addiction or use drugs and alcohol have, and we're going to talk about that in a minute. And there's also just with the COVID-19 precautions, social distancing, being in environments with a lot of different people. It's just, that this population, these folks, have just more difficulty with those kind of things. And we all have difficulty with social distancing by all means, at our Oakdale Recovery Center, our residential environment. We're continuously having to tell folks to spread apart, wear your masks and those kind of thing. And part of it makes sense. They'd much rather, they'd much rather sit at a table with 4 people playing cards and 2 people, not doing much interacting. So, and especially in that early recovery time, you're just looking for connection. You're looking for someone to share with or get support with. And social distancing and everything else has really, impacted that, especially in the beginning of COVID and everything else. So I talked about barriers to healthcare. So some of those barriers in regards to substance use disorders, part of it is stigma. There's obviously, and we've talked about it in these meetings before, there's obviously a stigma to those folks who struggle with addiction. They're reluctant to seek medical care. They don't, there's a trust factor there. There's a fear factor where if my doctor finds out that I'm using drugs and alcohol, are they gonna stop treating me? Are they gonna take away the medication that I'm getting for this other disease? Are they gonna take away that because they don't trust, they don't like, the interaction of those drugs and alcohol with that medication? There's a lot of shame that these folks feel as well. And having to admit that, yes, I am addicted to drugs and alcohol. So that stigma really stops him from reaching out to other people. And then the medical community, there's still a stigma out there as well. And we've done a wonderful job the last 5-10 years, especially at really educating the medical community on that addiction is a disease, that these folks are sick, that it's no different than other diseases that they treat. But hasn't gotten to everybody. And so these folks, are looked at as, they're lazy, they don't care, they're selfish, they don't understand that lack of control that goes along with addiction, along with use of substances, or anything like that. So, there's a stigma that stops them from reaching out to healthcare, reaching out, for resources. Vaccinations, vaccinations are everywhere now. Well, anybody can get. I just read today that now it's 12 years and up. It used to be 16 years and up. Now it's down to 12 years and up. And we have so many sites and so many, ways to get that. But those resources, resources are not always there for folks who are struggling with addiction. They're not, and it's just, they might not have the knowledge. I get a lot of information just from Higuera, and working at Higuera, I get access to a lot of information. I was able to get vaccinated back in January and February because I was an employee of Higuera. Those are advantages that I have. Folks that, might be unemployed, might be, again, don't have a lot of resources, lack transportation, the ability to drive, what have you. They're not going to have that knowledge, not going to have those resources. And then also, most of these have two injections to be vaccinated. So, we, for example, at Oakdale, we're able to take people to get vaccinated, and we're actually going to have a lab coming in soon that'll come in on a weekly basis and vaccinate people, which is wonderful. But they're not with us for 2 months or whatever. If they've been with us for a couple of weeks, they decide, okay, I'll get vaccinated. Then they leave 2 weeks later. Somehow they got to get to that second appointment 2 weeks after that. And while we'll try to set them up with aftercare options or what have you, it's more difficult for them to be able to get back to that site to get that second vaccination. So again, there's just more barriers. And then there's less treatment opportunities. Unfortunately, that's, COVID has had a major impact on the behavioral health, treatment setting. There's decrease in withdrawal management and residential beds. We have 45 beds at Oakdale. Because of COVID, we decreased that down to 35 to promote social distancing. We're not the only one. Every residential provider had to do that, not only in Wayne County, but throughout the state. So there's just less beds for these people. You've got more people using substances, using more intensely or what have you. And you have less beds for those people to use. So there's longer waiting lists, longer waiting times. Virtual versus face-to-face services. Everything before COVID was face-to-face. We didn't do much virtual, many things virtually at all. Virtual really had to do with folks in the more rural communities. But when COVID happened, we all had to do a 180 and we all had to get virtual services going. And there's been a benefit to that, but it's also been a barrier. It's been a wonderful opportunity for people it's opened more doors for people, that you just have to have a smartphone or you have to have, a computer. And when we first started with virtual at Higuera, for example, we just did phone services. We called you on the phone. If you couldn't get online, okay, we'll call you on the phone. We'll do a session over the phone. So it's given a lot more opportunities for people, but, just like this meeting, this is a wonderful, venue for us to do this, so to speak. We have the opportunity to do these meetings via Zoom, but as we said earlier, it'd be much nicer, and we would certainly enjoy it more to be together and to be face to face and be in a room together, and there's more connection that way. And same thing with treatment services or what have you. If you're working with a therapist, you're getting benefit out of that virtual treatment, but you're also, it's not, you might not get as much out of that session without being face to face with that person. So sober housing has decreased. There's some shutdowns. A lot of programs have shut down. There's a loss of revenue because of COVID. So there's less opportunities that way. And then also in residential environments or housing environments or anything, when you have one patient test positive for COVID, then everything has to shut down. You're missing shutdown. And so again, less opportunity for people to get services. we have less beds. Now, all of a sudden, let's say Oakdale, for example, is shut down to admissions for a couple of weeks while we work through this whole COVID process. That's 35 less beds that are available to people in Wayne County. So it's just, there's been a lot of barriers that have been, as a result of COVID. However, we always like to look at the positive too. We don't always want to look at the negative, and then not everything is horrible. So, excuse me. So there have been some positive changes to the substance use disorder, treatment community and recovery community as a result of COVID-19. So again, we talked about virtual formats, and it has eliminated some barriers to accessing treatment and services. Well, there, AA meetings and smart recovery and all those, they have a lot more virtual formats now for people. So there's a lot more. Everybody's becoming more comfortable with that aspect as well. So that's been an advantage in a lot of ways. Medication-assisted treatment, methadone and buprenorphine and naltrexone, medications to help people with their substance use disorder. There have been a lot of changes in that field as well. They can have telemedicine versus face-to-face. You used to have initially you had to have a face-to-face appointment. Now they loosen that up a little bit so you could do some virtually. There's longer take-home times for methadone. When you first start with methadone treatment, you have to go into that methadone clinic every morning. Then eventually you'd be able to do take-homes maybe a week at a time. They extended those to where it could be up to possibly a month, depending on each individual situation. So there's been some expansion of the rules and regulations regarding medication-assisted treatment to help people access those services. There's been an increase in mobile programs with the philosophy, you can't come to us, so we're going to come to you. We at Higuera have increased our mobile programs, but there's been other ones that'll go into the community and to the person and continue to eliminate any kind of barriers. You can't get to us, we'll come to you and we'll provide those services. You're in a setting we can't get into because we can't go into the building, but maybe we'll be outside and people can come outside and get those individual services. So there's been an increase in mobile programs. There's also been an increase in funding, and don't get me wrong, we have not financially, we have not done well in the treatment community because of COVID, and certainly have lost a lot of revenue. But there has been focus, obviously, in the state level, the county level, of increasing funding to assist getting through this process, and whether that be accessing and obtaining PPE and other assistance. There has been some increased funding and increased in different programs created because of COVID. So, there's been some positive aspects to it, but we in the treatment community understand that this is a long road that we still have to go. And even once we get to normal, whatever normal looks like, and get through this pandemic, there's still going to be long-lasting after effects for people. Those emotional and mental and behavioral consequences and impacts that they've had because of COVID, those are going to continue on, and those are the things that we'll be dealing with for a long time. And we're certainly ready and prepared to deal with that, and we'll continue to do so. But I appreciate everybody's time and attention, and now I will turn it over to Melissa.
Hey, Scott, before you turn it over to Melissa, there was just a quick question that I think needed some clarification.
Sure.
The question that came through the chat was, do you have mobile methadone units, or were you saying that people get longer take homes for methadone and that the mobile unit program was expanding? That's what you meant, right?
Right, correct.
That's what, yeah, somebody had thought that I think it was Kelly, thought maybe you had mobile methadone.
Yeah,
I don't think
me.
so.
I was about to say that's kind of interesting, but
right.
okay.
No, I don't know of any
Thank you
mobile
for
methadone
clarification.
programs. No,
Yeah.
mobile programs, where they're going out and doing harm reduction techniques, or making Narcan available, or a variety of different things going in. We have programs where we go into the hospitals and like I said, go where the people are versus waiting for them to come back to us.
So similar to like the units at the health fairs when they have the mobile units there taking blood pressures and stuff like
Yep,
that.
they're not our programs, but there are other programs like that, correct?
Okay, thank you.
Sure.
Thanks for clarifying.
Okay, I guess I'm on, huh? I do not like following Scott when he presents, so he knows that. And actually, I don't like following Chris either, who presents after me. So, but that's okay. Thank you so much for having us today. Really appreciate it. As Scott said, we are a behavioral health organization, Higuera Health. But what I wanted to point out about Higuera is we recently became a certified community behavioral health clinic, also known as a CCBHC. So That's going to be an acronym or term that you're going to hear as we proceed into the future, as Michigan has a lot of now CCBHC providers in the state, which is great. What a CCBHC does is it opens access for individuals who may be underinsured or uninsured. And that's excellent. We have a lot of individuals that come through our doors, for example, that can't get specialty services because of their insurance. They might have Blue Cross Blue Shield, for example, but can't receive a sort of community treatment, or their children can't be in a wraparound or home-based program. So this funding that we just received in 2020 really allows us the opportunity to get out into the community more and provide more services for people. So Higuera offers 30 programs and services to the community, substance use disorder and mental health, as well as youth prevention, primary care, and then we also operate community outreach for psychiatric emergencies, also known as COPE. So we hold the contract to provide adult crisis services in Wayne County. We also offer crisis residential programs too. So we have 6 locations, those 30 programs and services, and one of our more recent programs that we just developed and received grant funding for is called Pathways for Suicide Prevention. And that's our latest, newest program, really designed to meet people in the community, in the hospital, provide rapid treatment to individuals who are experiencing a suicidal crisis, had one, made an attempt. So we are providing the follow-up service right out of the hospital, which is the highest risk for suicide, 300 times greater risk actually for suicide is right out of an inpatient hospitalization. So we have been providing that service for 6 months, treated 63 people, which doesn't seem like a lot, but in times of COVID and not being able to get the referrals that we really needed, we're doing everything in our power to get out there and get those referrals in the door. So I'm gonna go ahead and share my screen. I don't know if I'll, doesn't matter, right, how many times I've done this. Sometimes I don't do it right. So let's see here. No, that's not right. All right, hold on just a minute. Let me do it this way. Shoot. What did they say? Zoom happens, right? There we go. All right. No, I don't want to record. Ah, sorry. This is not good. Let me stop. Hold on, one more time. 3rd time's the charm, right?
It happens. It's okay.
I
Take your
know,
time. I get flustered when I'm trying to do that as well. So
We're
All right.
with you. We got
Can
you.
you see my screen?
no.
Scott's gonna make
Did
fun
you
of me,
hit
I
share?
know. I
at
thought
the
I
bottom?
did. Let me try this. I'll get there. Now, can you see it?
Yes.
All right.
Good job.
Thank you. Takes me a minute. I present usually weekly, so I'm actually surprised I struggled so much, but that's okay. So I just want to go over just some facts and figures for you all. What we've heard over the course of the last year is that suicides were on the increase, that they were on the rise. And so just to put everything in perspective, suicide is the 10th leading cause of death, and homicide ranks 16th, but we do hear about homicide more frequently than we hear about suicide deaths, and it is the 2nd leading cause of death for youth. But there has been a decrease in suicides. So while we've heard, and we heard very early on, right away in March, that suicides were going to increase as a result of COVID-19, they really haven't. In fact, they've decreased in 2020. Suicide claimed 47,000 lives about in 2019, and then that dropped to just over 44,000 in 2020. So that is, we're cautiously optimistic in the suicide prevention, postvention world. That really speaks volumes to the amount of work that is going on now with suicide prevention and postvention. And when we talk about suicide, we oftentimes talk about prevention a lot, but we don't really talk much about postvention. So I will share some information about that. And just to put things into perspective too, sometimes we hear this stuff. That doesn't mean there aren't crises going on. So while there has been a decrease in suicides, there has been an increase in the reach out for crisis services. So we have seen an increase in that in 2020. So approximately every 11.1 minutes, someone dies by suicide. That's 1.1 approximately attempts annually, although I will say that there are probably a lot more attempts than that. Those are really underreported. Oftentimes there may be an attempt where somebody wakes up in their home, never goes to the hospital, never reaches out to behavioral health treatment or medical treatment, or they're aborted attempts. Somebody may stop them, but as Scott mentioned earlier, due to stigma and other reasons, people don't seek treatment. But there has been a 5.6 decrease in the last 3 years, and that's really great news to hear. So I am, as mentioned earlier, I am a survivor of suicide loss. I've lost 2 family members to suicide. I lost my grandfather and my uncle. My grandfather died just a couple of months before I was born, and my uncle, who was 16 at the time, was witness to that death. And that really followed him throughout his years. And it really changed the trajectory of our family as well. So for every one loss, when we think about that, there are about 115 people, probably more like closer to 130 people impacted by that loss. And at least 6 of those individuals that are impacted by that loss really have devastating effects. And that was the case with my uncle. And back then, and I don't want to date myself, but I guess I will, in 1973, there wasn't suicide prevention programming. There certainly wasn't zero suicide. And there wasn't really a lot of trauma-informed treatment programming going on. And my uncle turned to drugs and alcohol. So that was how he was able to proceed with his own life during that time. It wasn't until I was 16 years old that I realized or was told or informed that my grandfather had died by way of suicide. And that was after my uncle made his first attempt. So at that point, he was using alcohol regularly, not sure about his drug use, but it was devastating. He did end up going into treatment about 3 years after that first attempt, and he was sober for 19 years. That's when he relapsed, he slipped, and did not think that he could come out of it. And he and I had multiple conversations. This was in 2008, trying to get him into treatment and then getting him the help that he needed. He was hospitalized. And I think one of the things that we tend to do is when someone's hospitalized for suicidality or a mental health condition, we kind of think, oh, well, they'll be better after that inpatient stay. And that's what I think back then we all thought. So when he came out of the hospital, we felt like he was in a good place. That was a good place to be. And that's when he died. So that's why I talk about postvention services being so impactful and so important, and making sure that when we are talking about suicide with an individual or their suicidality, that we're making sure that we're finding them treatment for that as well. And that's something that I think in the substance use disorder world, we haven't really done a great job of across the board. In fact, we are a zero suicide organization. So what our focus has been on over the last 3 years is training and development of suicide pre- and postvention services for our staff. We've trained all of our staff in evidence-based practices to support that, as well as develop policy and procedure. But one of the areas of focus is substance use disorder and the impact that has with suicidality. I just reached out to a zero suicide consultant that we use, and she said the same thing. This is across the nation. People have not been really focusing on suicide and substance use disorder, and that really does need to change. So as we talk about suicide and suicide deaths, these are the methods of 2018. These really haven't changed much. Firearms continues to be the most frequent use, as followed by suffocation and then poisoning for suicides. And then we, really want to focus on what the risk factors are. And as I said, obviously, substance use disorder, history of substance abuse, those are major risk factors for suicide. And really, we'll talk a little bit about opioid use and suicide deaths. But These are just some of the risk factors. The long and the short of this is that suicide is very complex, and there usually is not one reason why people die by way of suicide or why they attempt to take their life. It usually is a multitude of issues and problems, and when you use alcohol or drugs, it exacerbates those things. And so it really can be more of a major risk. When we take a look at other risks, physical disability or illness, we have seen actually, when you take a look at suicide deaths across the board, Black teens, boys and girls, have started an increase in suicide, as well as older adults over the age of 85. And so a risk factor for older adults, we're seeing more completions in nursing homes and in assisted living facilities, more than we ever have before. And that could be due to physical disabilities or illnesses, loss of independence. But really, even with all these risk factors, there is a theme, or some theories that have a theme of burdensomeness, isolation, and not feeling belonged to a group. So when you have all these risk factors and you have those other kind of areas of concern, the burdensomeness and the isolation, that can certainly increase that suicide risk as well. Losing a family member or friend to suicide, and that really is where postvention comes in. After there's a loss of life to suicide, a lot of people don't know what to do. They don't know where to go to get help, to get that support that they need. I know that after my uncle died, I did not know where to go. And there was still, even as a licensed professional counselor, even as somebody who worked in behavioral health, I didn't want to share that information with anybody at that time. And I look back on it and go, oh my gosh, there was so much more to learn about that whole process. I had reached out for grief counseling, but that was all I received. I didn't go to treatment. I didn't seek out treatment for help or anything else. And I think I was only in like a grief support. It wasn't even a group. It was just me with Angela Hospice, who happened to do it. And I think it was just for a couple of weeks. But it took me a year to even really refocus. It was so devastating. A loss of suicide is so incredibly devastating. So, when we have experienced a loss like that, it's like in my opinion, it's like no other death I've ever experienced. And so it took a lot of time to kind of even figure out how to go through that grief cycle. Still go through it today. Every now and again, even when I present, I sometimes get choked up thinking about it. It's just natural. I mean, I think that's just part of being human. That we go through those kinds of things, and I support that. And when we present on suicide education, and I guess I should have said this too, that this can be very triggering to people. Talking about suicide can be triggering. It's important. We have Scott and Chris on the line. You can of course message them if you feel the need that you want to talk to somebody. But it can be, devastating. It can sometimes put you right back to where you were in the moment where you found out. So that's why postvention is so important, because it isn't a linear process of grief. It goes in waves, just like I'm sure like all different types of grief do. But anyway, so those are some of the risk factors that we talk about when we talk about suicide and suicide pre and postvention. Talking about substance use disorder and suicide too. So suicide deaths are misclassified oftentimes in medical examiner reports. They're undercounted, especially with opioid use. And that's kind of a scary thought, but I will say that it's underreported, not just because of substance use disorder too, it's underreported in general. There really isn't a standardization in our state of reporting. And that really provides challenges. It's a hindrance for the people in the treatment community, because we really don't know in our communities then who were suicide deaths, who weren't. And while we get a number here in Wayne County, I think Wayne County does a better job. Oftentimes you see those underreported suicide deaths or misclassified deaths in rural communities. And that's just a fact. Smaller towns know people, and they don't want people to know that someone died by way of suicide, because of the stigma and everything else that goes along with it. So they tend to underreport. Also, medical examiners won't report that it's a suicide death unless they have a clear indication that it was. So that means a suicide note, or, you know, what they tend to ask, you know, is, was there a mental health condition? Not everybody who dies by way of suicide has a mental illness. So there's a lot of work that needs to be done in this area. And our state of Michigan, has a Michigan Suicide Prevention Commission now. And this is one of their areas of focus, is data reporting and reporting standard, like a standardization process for this. So very exciting information there. But I think that'll be helpful as we proceed with this process. Suicide deaths involving substances has increased. So in 2017, for example, opioids were involved in more than 40% of suicide deaths. So those who died by way of suicide, there was opioids in their system. And I'll show you a slide in a minute that kind of, well, this was kind of from 2016, but it'll show you the different drugs and alcohol percentages. And the presence of substance use disorder is a high risk. We know this, as I just mentioned before. For opioid use, double the risk for women, and a 30% increase for men. And the greatest risk are those using opioids regular, 75% more likely to make a plan and 2 times more likely to attempt. So, you know, those are eye-opening statistics, or facts that we need to do a better job, like I said, in the treatment community, addressing these issues too. So this is kind of the study I mentioned. This was from 2018, actually, alcohol and drug use study. You can see that based on this table, that the positivity rate of the alcohol or particular drug in a suicide death. So 40% positive for alcohol, 26.6% for opioids, although they suspect it's closer to 40% now, 30% for benzodiazepines, 6.3% for cocaine, and so on. So, you know, this is so important as we talk about treatment and treatment options and what's going on in that world too. But not only treatment, but also what we need to be doing in the community too. So, of course, the link between opioid use and suicide, and it actually could be, you know, the link between alcohol as well, as impulsivity, the inability to make clear choices at that moment, reduced social networks and social circumstances, and it alters the perception of pain as well. When we look at, I don't know if you've heard of the Violence Triad, but there's, you know, if there's firearms involved, depression involved, and drug or alcohol involved, that's an extreme high risk and a huge warning sign that we need to be doing more. So when we do our gatekeeper trainings, when we talk in the community about suicide prevention and postvention services, you know, we do tend to talk about lethal means and access to lethal means and what that looks like. And we talk about drugs and alcohol. We make sure that we talk about how there's a link and that we need to be doing more with this. If you take away someone's access to lethal means, they typically don't go and find another method. But that's hard with drugs and alcohol. That's tough. You can take away someone's gun or another method, but when we look at drugs and alcohol, it can be much more challenging. So we talk about suicide warning signs as well when we do our trainings, and I wanted to just show you this visual. You can see that there are a lot of warning signs. Some require immediate assistance. You know, that's when we do tend to either involve crisis services immediately or dial 911. That's when somebody is threatening, has an access to lethal means, and is using substances that requires immediate intervention that we cannot wait for. But as we, you know, training in question, persuade, refer, we talk about these warning signs. Not all of them require a 911 call. So, but it does require thoughtful conversation. And I think that's something that people really tend to shy away from, they're afraid of. And when we talk about gatekeeper training, question, persuade, refer, for example, that's a 3-step evidence-based model that teaches individuals how to talk to somebody who may be suicidal, how to kind of get over that fear, because it can be a very scary subject to talk about. And so one of the things that though we focus on are the different warning signs too for that. frequently talking about death, feeling like a burden, as I mentioned, isolation, hopelessness. Those are 3 big concerns. Oh, yay, Nicole, QPR. Yes, I see that. There's a booklet for it. So, and then and it's interesting because there's been studies that have come out recently too that talk about, oh, well, different patient populations need different interventions. And really, when it comes to suicide pre and postvention, it doesn't. They don't need different interventions when it comes to questioning them and persuading someone into treatment and then getting them the referrals and the resources that they need, which is a great thing because that means that we can train multiple people from very diverse backgrounds in suicide prevention, and they can help even more individuals. So that's a really positive part of suicide prevention. So where do we start with this? It seems like such a lot to unpack with suicide prevention and postvention. And, as I said, one of Higira's area of focus has been on training clinicians and non-clinical staff as well. But, as I will kind of talk about what we've done with our Zero Suicide Initiative, training was something that our staff told us they wanted to. So we did a big workforce survey and our staff said, I don't feel confident working with somebody who's suicidal. And that's a really scary thought. If you think about it, it really kind of made me realize that I did a little bit of digging, I guess. And in our state, in Michigan, clinicians don't need to be trained in suicide prevention. I think it's assumed we get it in our education, right? But we really, and while we do, it really isn't intense. So it really isn't focused on evidence-based practice. I think it's going to probably start to get there. But our clinicians were starting with us, or we would have interns come in and they weren't trained in any of this. We had to really start from scratch. So our focus was training all of our non-clinical staff and our clinicians on suicide pre and postvention, so education. That's what we started with in the Zero Suicide Initiative. And then we made sure that our clinicians were trained in a myriad of things, including safety planning, screening and assessment appropriately. When somebody comes in for an intake, whether that be for substance use disorder or mental health, if they tell you that they're suicidal, we stop everything at that point. Our focus is on that suicidality and making sure that we have a plan in place, a safety plan in place, and we're counseling on access to lethal means. That wasn't really happening before. People would come in and they'd say, yeah, I've had feelings of it. And then we proceed with treatment. And I've read cases where, we've talked about it maybe for a session, and the next session somebody wanted to focus on something else. So we never came back to that suicidality. And, the evidence-based practices really show that you do have to focus on that. The one that we really utilize the most is collaborative assessment and management of suicidality. And that focuses on the drivers of suicide. What brought you to that place? And we're going to develop a safety plan around that. We also use cognitive behavioral therapy for suicide prevention and dialectical behavioral therapy as well. But CAMS is the main one that we focus on. And then, as I said, all of our non-clinical staff and clinicians now are trained in question, persuade, refer, that 3-step model that I mentioned, really focusing heavily on how do you talk to somebody who's suicidal? What can you do? And really kind of easing the feelings of fear around that and looking at hope and building up the hope for those individuals that are feeling that way. So that's really, have been our focus. And then our non-clinical staff said to us during training, this is great. We do this, people come in and we'll see them, but you really need to do this out in the community. You should be focused on the community and their needs, because our clients go home at the end of the day, right? So they're at work, they're at home, they're at school, and the more people we train in this, the better. So we did a big suicide prevention campaign, and we've trained over 1,000 individuals now. Most recently, we trained Wayne Westland Schools, all of their staff, and Northville Public Schools, their high school staff too, and we're going to be doing their middle school staff. I mean, that's amazing. The schools are really starting to know the importance of this, and it really is meaningful. And Chris is a QPR trainer. He didn't mention that in his bio, but he is a QPR trainer and soon to be master trainer as well. We've trained police. We've been to PFLAG meetings and have trained. We've trained Livonian Chamber of Commerce. We're out there, Wesleyan Chamber of Commerce. So, and then we did recently in May, as Mental Health Awareness Month, we trained over, I think, 50 individuals to actually become trainers now too in the state. So that's amazing. And it's so needed. It's needed throughout our entire state. Governor Whitmer just declared the third week in May Suicide Prevention Training Week as a result of our efforts. And so we're really excited about that and want to continue that into the future. So, so that's what we're doing. But, you know, to kind of think about this, when you're working with when you're with a loved one or with somebody in the community that you're going to help, we want to just be mindful that we want to make sure we're finding the right fit for that individual for treatment too. And if somebody's feeling suicidal and they're using drugs or alcohol, we want to just make sure that you know where you're referring to. You know, oftentimes we'll do a referral, or people in the community will do a referral thinking that, okay, they're in treatment, so everything's going to be okay. And that's not necessarily the case. We want to know the treatment background. We want to know what that counselor has been trained in, what their specialty is. And if that specialty is suicide pre and postvention. You know, thinking back about my uncle, he was in treatment after the hospital. I can pretty much guess, based on what I know now, that there wasn't a whole lot of postvention being done. I know he wasn't in any groups. And, you know, I can't go back to 2008 and think about that for very often. But I will say that it is something that I know now when I'm going to be talking to somebody in the community, I'm going to know who I'm referring them to, because I don't want to just refer blindly and hope for the best. So that is something to really consider, you know, what that person's, you know, what their specialty is, as I said, and what their training is. And that they really should be trained in an evidence-based practice. You know, those are there for a reason. They have had a ton of research done on them, and they've been found to be effective. So just to keep that in mind as well. So my last kind of thought is really, you know, what can you do? What can we all do together collectively? Look for those warning signs that I mentioned. Show that you care. Hope really, and I know that it can be very challenging. I know that from my own experience with my uncle, that, you know, half the conversations I had with him before he was hospitalized, he was intoxicated. It was very challenging and very tricky and very hard. But I showed that I cared. I called. You know, at the end of the day, we have to do what we have to do to show that we care. And at the end of the day, after I would talk to him, I knew I did everything I could do. I don't know that there's anything else I could do. So, you know, that's what we have to just make sure that we continue to do. And it's hard. I understand it. It is very, very challenging. But kind of instilling that hope can make a difference. Again, ask if the individual is suicidal. Again, that's hard to do because we're always afraid of what that answer is going to be. And if it is yes, I am, then we have to act on that. There's something more that we need to do. And that can be restrict access to lethal means. That's really what we want to start with. So if there is a particular method, we want to try to make sure that we're not leaving it available for that individual. And that can be tricky too. As I mentioned, firearms is the most common method. And, you know, when you talk about gun laws and rights, and it can be a very challenging conversation to have. But there are opportunities to get support in the community with the local police so that they can hold the weapon, not weapon, but firearm, things of that nature to consider. And then get help. And that's really what I mentioned previously, is that we want to make sure that we're reaching out to get help in the community from providers that really are focused on suicide pre and postvention services. And this is from the Michigan Suicide Prevention Commission report. That report came out in March 2021. It's on michigan.gov's website under suicide prevention. I encourage everybody to read that or at least peruse it. It's got a lot of really good information and what the strategy is related to Michigan of reducing suicides in our state. Our state has really taken a proactive approach to this. I'm very pleased to hear what they're doing. I sit in a post-vention work group, and they really are trying to standardize programming and evidence-based practices across the treatment community and training. And so that report is kind of long, but it's readable, it's doable. So I do encourage everybody to do that. And I also can send the link if needed. So that concludes my discussion.
Thank you, Melissa. Chris, it's all you.
Thank you. And yep, I have to modify my bio. I didn't realize that till my introduction. I was like, oh, I should have put QPR on there. I just wanted to make sure I didn't put home a new vision. That was the most important part at the time. They don't pay me anymore. So I'm here to talk about my personal and professional experience during the pandemic, because it affected me in a lot of different ways. And so it was a good setup with Scott talking about SUD and Melissa focusing mainly on mental health issues and suicide prevention and post-vention, which is huge. Yes, I am a QPR trainer, and I just recently trained an entire group of students, which was, I thought it was easier than I thought it would be because they were pretty quiet. But I've taught large groups of teachers, and I've noticed that, and Melissa and I have talked about this, I tend to get people hanging out afterwards, wanting to talk, and kind of forgetting that I'm not a clinician. I try to tell them that in the beginning of the training, and you know, they just want to talk. They didn't have the nerve or the courage, or they just didn't feel like sharing what they experienced with the group. They wanted to keep that to themselves. So just like a Zoom meeting, you know, when it's over, you watch all the faces disappear. And I've had consistently one person hang out, and I make sure I'm the very last one to leave, because there's always somebody that wants to either share their story or ask a very personal question. And just like usual, if I can answer it, I answer it. If not, I try to get it for them, or I refer them to in a different direction or towards someone that could help them. So I'm not a peer support specialist officially, but I've done a lot of peer work with mental health and as well as substance use. It is my main source of help. So I will start with, we'll just go right into it. Last year, I was running the Engage program, and like we've said, is a mobile program. It's us going in and out of hospitals. It's expanded now into other areas besides hospitals. We're working with some fire departments and police departments as well. But back then, our primary source for referrals was hospitals, and we would get the referrals from social workers mostly, sometimes doctors and sometimes nurses, but mostly the social workers or caseworkers or case managers, however they're referred to. And I've had my fair share of stigma. I've had to actually stand up to doctors, which it was pretty cool, especially when it worked. And I got them to let our clients stay an extra day so we could have an extra day to try to figure out their treatment option. Anyway, that started in 2017, that official program. And I had some experience with working with hospitals in Ann Arbor and Ypsilanti. So it was a good fit for me to run this team, I thought. That's why I took the job. And we did a lot of work, and I watched it all come crashing down last year. Not to sound dramatic, but that's how it happened. We, just like everybody else in this room, I was watching the news, and I was starting to get a little concerned about not just my personal safety, but like my job security and my safety of my team and the safety of our clients. And like, what is what is going to happen when the hospitals fill up? And I noticed that the tables that people had out with the hand sanitizer and the questionnaire got closer and closer and closer to the parking lot, meaning eventually they get you right at the front door. And then eventually they just shut that door. I got a message from one of my staff members. His name is also Scott. And he said that he talked to Scott Shadle. He called me and he said, Scott just called me and told me to turn around and go back to the shop. I said, really? And he said, yep. Higuera has decided to we call it ground. I know we're not in planes, but Higuera decided to ground all the teams, including our mobile mental health teams, which is called COPE, Community Outreach for Psychiatric Emergencies. And so I said, well, I kind of saw this coming. So I called Scott Shadle to confirm. And he said, yeah, we decided to do this before the hospitals decided to do it. And some of the hospitals had already decided to do it. We were really trying to pull some strings and we were already having a hard time getting in to see our people. So that's what happened. Obviously, personally, I started to get very nervous for the team and for there's a lot of uncertainty. Going all around the world, and I was just curious on what was going to happen to my program that I helped build and put together, and what was going to happen to me professionally. And not too long after Engage got, I'm not going to say shut down, I'll just say, put on hold, because it's still around. I ended up going to Oakdale, and they did not have official peer leadership, but they had peer recovery coaches there for a long time. And so they thought that would be a good fit for me. So I ran the peer team. Fortunately, by the time I got there, some of the peers had already decided that it wasn't safe for them to be there, like a lot of other staff. So they had left. This is April, May 2020. So this was a lot of situations were happening. Unfortunately, I already lost a friend of mine and a colleague that I knew even before I worked at Higuera. I knew him for a long time, and he unfortunately caught COVID and passed away. And so it was just a very hectic, crazy time. And I'm in recovery, and everybody I work with is in recovery, and some of us are co-occurring. So while we're all worried about what's happening professionally, I had to remind myself, hey, you need to make sure you're okay, and check with your team. Let your bosses know how you're doing, because they're busy running around trying to run all the different programs that are going on with Higuera, and they're also worried about their families and their friends. So it was a very, very hectic time. Things settled down, and I ended up bringing some people over from my Engage program over to Oakdale, and we just kind of filled this huge gap with a lot of staff that had left. Most of them came back, but there was an issue with safety. Some people had legit health concerns that they might, they were more susceptible to it. So we were doing some other groups. We were working with the recovery techs. We were filling in their slots. We were pretty much doing everything. Wouldn't have been surprised if they told me to get in the kitchen and start cooking for everybody. So, which would have been great. I ended up settling down, and we started to form a program and form a curriculum, and we started to incorporate multiple pathways into Oakdale Recovery Center, which had never really been fully done before. And we had some new coaches come on that were hired on just to work at Oakdale. And while we had some staff kind of in limbo, so to speak, going back and forth from Engage to Oakdale. And during this time, I reconnected with my therapist, and I did some telehealthing of my very own, and I did a couple phone sessions, and made sure I did my own checkup from the neck up. I checked in with a lot of people from my recovery family, my Smart Recovery family, my AA family. I even checked in with my Recovery Dharma folks. I get around people. I know a lot of recovery folks. I was checking in with my non-recovery friends who were some of them were really struggling. And right to Scott's point, more people that drank were drinking more. People that used were using more. And during this time, our poor community, our addiction community, they kept, I mean, that didn't stop them from overdosing and going into the hospitals. We just couldn't do anything about it because the hospitals at this point for many months were just completely locked down. They wouldn't let any outside people in there. And yeah, as bad as I felt for the clients, there was, honestly, there was a part of me that didn't want to go to the hospitals either for my own safety, you know, my safety of my wife and my family. So it was a very, very, very difficult time. But we made, you know, we just kept moving forward, and we kept making the best out of a bad situation. And it did have some benefits. One of my staff members was working part-time for us and full-time for a restaurant that ended up going under, and it was a big chain. It just, they all closed. And she said, "What am I going to do?" And I said, "Well, come on over to Oakdale." And fast forward a few months, she's now full-time with benefits, working for Engage again. She's back, going back out into the field, doing what she loves. And now she doesn't have to work at the restaurant anymore, which she was actually kind of happy about that. So, you know, that kind of stuff happens. One of the things I wanted to point out when I was trying to make little notes, just to make sure I point to certain things during my time, was when I got back to work, I missed a kind of important part. There was a time where I caught COVID, and I was one of the first people that I knew that caught it. And it was I was also one of the first people that caught it that was asymptomatic. So there was an immediate, obvious panic with everybody that I knew, everybody I knew online, family from across the country. You know, they just didn't know anybody. And I had friends that would lean left, lean right politically, and all of a sudden, you know, it was just kind of this unifying moment. I'm like, great, all I had to do was get COVID to unify my family. Awesome. So, but I did a daily log, and I ended up working from home because I never had any symptoms. And I, you know, learned a lot about Microsoft Teams and Zoom and Skyping and all that stuff. And I really kind of got into it after a while, and had some crazy fun backgrounds, which this is a real background. That's really my pantry behind me. But I had fun, you know, I made the best of it. And I luckily I didn't get too bad at cabin fever or anything. And when I got back to work, I just hopped right back to it and started making sure we were running meetings, and we were reaching out to people. And one night I was covering phones at the front desk, and somebody called me who was intoxicated, and I talked to her for a little while, and I tried to just, you know, comfort her and encourage her. And I told her the usual, you know, that we all say in Wayne County with Medicaid recipients, is you got to call that 800 number. And she was, of course, delighted to hear that. And as I was talking to her, I said, "So what happened? What do you think happened to you?" And she said, "Well, I couldn't go to meetings anymore, so of course I relapsed." And that I'm glad she couldn't see the face I made when she said that, because it was very like, "What?" And I said, "Okay, all right." And I just kind of went along with it, and that stuck in my head ever since. So, and I use that to work with my clients, and I'm definitely going to use it any opportunity I get to share, you know, in an advocacy setting or a presentation setting, because that speaks volumes about that person's recovery plan. Not knocking that person. I'm saying in general, recovery plans tend to be very thin because of the misconceptions from the recovery community that have been going on for years. And I'm a very loud advocate when it comes to multiple pathways, and not just multiple pathways means more than just, hey, there's more meetings than AA, because luckily that's getting to the point now. It makes me happy to see that I'm not the only ones yelling that from the rooftops anymore. That's kind of a given, that there's more meetings than AA. Multiple pathways means so much more than that. Like, there's other options besides going to meetings. There is getting your own outpatient therapist, getting in a fitness regime, finding healthy hobbies, new hobbies, old hobbies, getting into music, whether it's playing or listening or trying new things. I could go on and on. And I felt so bad for this person that she felt in that moment that was her recovery plan, was going to meetings. So therefore, by not being able to go to meetings, she, of course, relapsed. And I asked her about virtual meetings, and she kind of scoffed at that idea. And then that started getting me thinking about what things were like for me, 8 years ago, when I first started working, or I worked in the field for 10 years. At this point, been sober for 12 plus. But there was a time when I first started talking about multiple pathways and talking about virtual meetings. People would laugh at the very notion of going on to an online meeting. They would say, Chris, that just doesn't work. You got to go for the face-to-face. You got to have that experience. You got to, I don't know, hold hands and hug and pray at the end of it. And I said, I don't think that's true for every single person. I've met clients that have said, I can't go to meetings. There's too many people there. They have genuine diagnosed disorders, anxiety disorders, if you will, and they can't be ignored. You can't just say, suck it up and go. Some people are going to, if you do that, they're going to go to these meetings and they're going to retain nothing. They're just going to be freaking out on the inside the entire time, not absorbing any of the material and not hearing any positive messages. They're just going to be thinking, oh my God, I don't want to be here. And granted, that's the case for a lot of new folks, but I've been an advocate for that for a very long time. And there was some strange satisfaction that I felt with this resurgence and insurgence or whatever blow up of online meetings. And there were a couple times where it was just like, at the same time as I was happy, I was kind of irritated, because I was like, these meetings have been here the entire time. These meetings have been available since 2019, 2018, 2017, and just going further back. They've been around for 10, 20 years, some of them. Smart Recovery has had virtual meetings and chat rooms and all kinds of other online options since they started over 25 years ago. AA's been around, they're pushing 100, but they've had online options and phone-in options for years. It's just some facilities choose to not do the research and provide all the resources to their clients. And at the two places I've worked at, I make sure that that's what we do. That's what my team does, is we provide all the resources that are possible, not just the face-to-face meetings that are in the Metro Detroit area. We're going to try to, if we get a chance to work with the client one-on-one in a more intimate basis, we're going to get more detail. We're going to find out, all right, we'll find out meetings that are in your area, like in your hood. We're also going to find out what virtual options are available as well, because now most people have a smartphone. Most people all have access to a laptop or library or something. So I'm hoping that this momentum of virtual meetings, I know a lot of people are sick of them, but that option needs to stay. And I don't know what the percentage is, because I think the percentage is going to be different for each individual. I know it will be for me, because I enjoy the online option. I enjoy going home and taking off my work clothes and putting on comfy clothes. And if I want to go to a meeting, it's like, I don't really want to get in the car again. I can just go to a meeting and talk, or not, just sit and listen to the material. There's also YouTube's options and all kinds of other options that I'd be happy to put in the chat or send out to you guys after this. You guys can contact me if you want to. I'm always available. I love Lauren. I've been a fan of you guys for a long time. When we would go to when we would have engaged clients, and we'd be meeting a lot of the families too that are just spent, and they pull me outside of the room and they're like, please help us. And I'm like, I can, for you guys, let me help you. Like, look up Families Against Narcotics. I say FAN before I say Al-Anon, because that's how much I believe in FAN and how effective it can be. So with that, I'm gonna stop, and there's a couple minutes for Q&A. Thank you.
Wow. Thank you, all of you. From Scott to Melissa to you, Chris, I mean, what great information. Hagera is doing a really remarkable thing. And Melissa, I'm so sorry for your losses that you have endured. But, you know, so oftentimes, as we know, out of the deep pain comes great things. And I think what Higuera is doing for our state, we are very, very fortunate to have this program. And I love that you're in the schools. I think that's absolutely fantastic. So I haven't seen much come through the chat. Laura, did you want to say something?
I have a
Okay.
question. Chris, I would be interested in getting that list of virtual meetings and YouTube links and things like that for the people that the participants in the treatment court that we have at the 29th District Court. We're always looking for options for them. And, you know, the more options we have, the better. And I just want to say that, you know, we experienced a lot of relapses after the pandemic in our treatment court. And one of them was particularly hard. He was a really severe alcoholic, and his trigger was church, the fact that they closed the churches and he couldn't get into church. And it just was heartbreaking. But there really were no answers. I mean, we did what we could with him. And he did end up graduating from our program, but any resources that you have, I think would be great. And I see that you did put some things in there.
Yep, my email is in there
Email.
twice, actually.
Okay.
If you email me, I can send you whatever you need.
Okay, thank you.
You're very welcome.
Nicole, did you have a question?
Yes, my dinosaur cat that's almost 18 years old. We want to thank you very much, and just amazing each time we come each month. I do want to let you guys know from Higuera, so very proud of you. And I don't say it too often, but I represent your building in Westland. I work at Detroit Wayne Integrative Health Network, but I work very closely with Leatrice Bell, and we formed the Consumer Advisory Panel. And so once a month I'll sit in and review everything and take it back to Wayne County. And yes, so I got a special fondness for Higuera, and I do represent you guys. So thank you guys. Buddy, thank you too.
Thank you.
That's great. I did want to also mention, because Christine was kind enough to share a link. Believe it or not, they actually are looking, I think it was the DEA is looking at having a mobile unit for methadone. And so there's an article, if anybody's interested in it, let me know. You can email me, or I can put it in the chat if you're interested, so that you can take a look at the article. But I was very appreciative of that information. That's something I didn't think I would ever see. But, you know, we're ever evolving and ever changing in this new world that we're living in these days. So I guess that, you know, that's good. So Christine just put, Scott, Melissa, and Chris, I'm a nurse practitioner and I work with people who have substance use disorder. Thank you all so much for what you do. So,
Welcome.
yeah. So does anyone else have any questions for our experts and kind souls that are doing so much for our communities? I think that's it, guys. Well, I can't thank you enough on behalf of Northwest Wayne FAN and our entire board. We're so appreciative of all that you guys are doing. Truly, I get the fortune. I'm very fortunate to be able to work with Scott at various projects with my company and his company. And so this was really insightful for me to learn more about all the wonderful things that you're doing. So it's very impressive. So thank you so much. I'm glad that we taped these, because this is definitely one that I think people need to listen to so that they understand what's happening right around the corner from them. So thank you. And thanks everybody for your time this evening. We greatly appreciate it. And Chris, thanks for the shout out for FAN. We really appreciate you doing that. And as always, you guys just keep spreading the word about Families Against Narcotics. I mean, we're here for you and the people that you serve. So please let them know that. And I hope everybody has a good rest of your evening.
Take care, everybody.
Thank
All
you.
right.